So I'm not looking at that clock, but hopefully I'll be on time here. And Dr. Marcella already told you quite a few things about Malassezia. But let's go here. So I'll briefly talk about Malassezia, how it was diagnosed, the disease in dogs and cats, diagnostic methods, and treatment. In 1846, this German human doctor collected some samples from a very common skin disease in people called pityriasis versicolor, and found this round to over broad-based budding organism and named it Pityrosporum species at the time, and then eventually it was named Malassezia for the fur, okay? And then almost 80 years later, this other doctor, see, the literature doesn't say if it's a veterinarian or a human. I believe it's a veterinarian, but found similar organisms from samples from a rhino, that's actually a unicorn Indian rhino who had exfoliated generalized skin disease, very similar organisms. And he named it initially Pityrosporum pachydermitis, and eventually it was named Malassezia pachydermitis. That's how our Malassezia came about. And he treated this rhino with 1% salicylic acid mixed in fat. Malassezia loves fat. I don't know, but it improves. So as you know, Malassezia is part of the normal skin microbiota and mucosa, okay? So in general, there are 18 species of Malassezia. 11 of those have been identified in cats and 9 in dogs. But in both species, dogs and cats, the most common Malassezia species is Malassezia pachydermitis. Malassezia organisms are all, as Dr. Marcella mentioned, lipophilic. They need lipid to survive, to grow, and lipid dependent. Before we used to say Malassezia pachydermitis is lipid independent, but now we know they don't have a gene, it's fatty acid synthetase that would synthesize their lipid. So, and Malassezia pachydermitis always doesn't have that gene, so it's also lipid dependent, but somehow it's able to remove the lipid portion of one of the saburo-agar ingredients, that's peptone, and then it can grow in normal saburo-agar, but it's also lipid dependent. So, and if you are growing Malassezia culture, submitting for culture, they will supplement the media with lipid. So they are commensals, part of the microbiota. So what are the sites of the skin that they like to live? Ear canal, perioral lesion, it's perianal, interdigital, even anal sacs, and mucosa. So they are commensal. How come they can cause disease? So as we discussed, and Dr. Marcella mentioned that before, I didn't discuss this with you yet, but Dr. Marcella did. And so Malassezia dermatitis is a secondary problem. So there is, in most cases, not to say all of them, an underlying disease. So these diseases alter the skin microenvironment and other factors of the barrier. That then allows the Malassezia to overgrow and cause disease. Malassezia produces many virulent factors, and I'll show you quickly later on. So those virulent factors, if they are overgrowing on the skin, will be accumulated, and that will induce inflammation, and it will also alter the skin barrier further, okay? That's, again, the hypothesis we have as far as how Malassezia dermatitis occur in these animals. So just a few factors to support this hypothesis or theory. Again, these two papers show that 72 to 83% of dogs diagnosed with Malassezia dermatitis have an underlying disease. And again, not surprising, environmentally induced, food-induced atopic dermatitis is the most common underlying primary disease that predisposes them to develop Malassezia dermatitis. Keratinization disorders, Dr. Marcella mentioned quite a few diseases associated with keratinization disorders, endocrinopathies, okay, and even cancer, okay? So those diseases are there, altering the barrier, allowing them to grow. And all those are considered virulent factors secreted by Malassezia. By themselves, they alter further, as I mentioned, the skin barrier and add inflammation to the skin. Other virulent factors, melanin and biofilm. And here, just a couple of papers demonstrating that Malassezia organisms do produce biofilm. And I had cases of otitis caused by Malassezia that I highly suspicious that it was so difficult to treat because the Malassezia strains that were causing the otitis were producing biofilm because the exudate was very slimy, kind of grayish in color. About the disease in dogs and cats, again, first dogs, signalment, no sex or age predilection, but definitely breeds predilection. And I'm sure you recognize those breeds. So, Dachshund, white, I should stare here. So, miniature poodle, basset hounds. Basset hounds carry a larger number of Malassezia organisms in their skin, normal basset hounds. Cocker spaniels, Shih Tzus, and other breeds listed below. So areas typically affected, it will overlap with the areas where they like to live normally, but also groin, medial thighs. You can see in areas of fold, they really thrive in skin folds. So lesions, what do you see? Initially, erythema. With time, alopecia, but this is self-induced because Malassezia dermatitis is typically very pruritic, okay? Scales is a characteristic of Malassezia dermatitis. You're going to see that with most lesions, not always. Lichenification. And so it's interesting that if you induce a lesion in a laboratory dogs of Malassezia dermatitis, one of the things you see in the biopsies is, again, hyperplasia of the epidermis, follicle wall, and dermis. Okay, so they induce probably some of these inflammatory mediators or virulent factors that they secrete stimulate the epidermis to multiply. So keratinocytes divide and multiply. And so then if you see a dog with lichenified skin, think of Malassezia, look for it, okay? Greasy yellow skin, scales, okay? To red-brown material. So Dr. Marcella mentioned that. That's really a hint for you that Malassezia is very likely overgrowing in those sites. Yes, saliva contributes to that color, but my theory is that they also produce a pigment responsible for that. Because again, you see them on the nail folds and you see them in areas where the dog does not lick, okay? Again, I mentioned lichenification, hyperpigmentation. Again, those are lichenification and hyperpigmentation are skin changes associated with chronicity. And Malassezia may not be there, but if you see lesions lichenified and or hyperpigmented, look for Malassezia. Very pruritic, so it can induce itching in an underlying disease that's not pruritic, like hormonal diseases or keratinization disorders. They aggravate itching in dogs with underlying allergies, okay? So again, they love to overgrow in the folds. So lipids accumulate there, moisture accumulate there, and they overgrow and cause disease. look for Malassezia dermatitis. We'll talk about how to collect the samples again. So scaling there, quite lichenified skin. So, and I think that Dr. Marcelo mentioned also, be suspicious of Malassezia if you see an area, a lesion. It's erythema, it could be a little more pigmented, that's well demarcated. So bright red erythema, well demarcated skin lesion. Look for Malassezia, okay? And there you even see the lichenification too. 2 reasons for you to look for it. So again, pause, this brownish discoloration, be very suspicious. It's written there, I have Malassezia overgrowth causing dermatitis. Look for me, you'll find me, okay? And this dog was interesting because, again, I couldn't find an underlying disease on this dog. He came with this brown paws. He had also a brownish discoloration in the perianal region. I treated the Malassezia. The dog was perfect, never recurred. So I couldn't identify what was the predisposing factor here for Malassezia to overgrow and cause inflammation. Oops, no, never mind, I saw that, showed the nail, but I think you've seen this many times. When you see this is Malassezia growing on the nail plate because initially it grows on the nail fold, okay? And sometimes some dogs don't even know that they have it there, and others will be like crazy. Malassezia-otitis, we won't spend much time, otherwise they will make it stop, but look at the lichenification there. Erythema, lichenification in the pinna, you know Malassezia is there. But then you look at the brownish, moist exudate, all that tells, but you are doing cytology. You're not just guessing. Okay, it's another case. Look at the scales, the yellowish lipid material, fat material, sebum, coating the scales there. Quite severe erythema there too. Hypersensitivity, I think Dr. Marcella, so you learn those things, mention about hypersensitivity to Malassezia. So there are a few studies showing if we inject intradermally extracts of Malassezia, you have positive reaction in these dogs with atopic dermatitis that had reoccurred Malassezia overgrowth causing dermatitis. I don't like to say Malassezia infection, but so, and also same thing, atopic dogs with recurrent Malassezia can have IgE antibody against Malassezia. So again, and they aggravate the underlying allergic disease. So, and I question, is this a true hypersensitivity? Is this a true allergic reaction to Malassezia antigens? Or what we are seeing is a sensitization that's not leading to an allergic reaction. And all we see, it's really inflammation due to all these virulent factors that the organism produces. But again, I don't know, I could be totally wrong. And there is this study here that may be supporting the theory that these atopic dogs may indeed develop hypersensitivity reaction to Malassezia. And so, and they got 16 dogs that they did an intradermal test with various antigens. They reacted only to Malassezia. And they decided, let's try immunotherapy. And they did subcutaneous immunotherapy, and 56% of the dogs responded. And their benchmark for response was 50% at least decrease in itching and reduction in the medications that the animals were. And they did it for 10 months, I see, okay? And again, there is some evidence there, but I'm not quite convinced yet. And again, I just don't know. I don't like to say for sure that that's what happened at this time. Disease in cats, there is no age or sex predilection. Devon Rex and Sphinx not only have more Malassezia organisms compared to other breeds on their skin, but they can develop seborrheic dermatitis caused by Malassezia. So in cats, again, areas typically affected, face, ventral, axilla, groin, palm, similar to dogs, okay, can be actually anywhere. Lesions start with erythema, itchy, often self-induced alopecia. Again, you tend to see also that the greasy material accumulated on the surface of the skin or scales, the coat scales, okay? And the adherent brown material. That brown material on the skin, so you have to think of malassezia. And sometimes, again, you'll be just due to licking, but be suspicious of it. Pruritus also commonly present. So it can complicate cases of chin acne. Okay, so a cat with chin acne, that's the area where malassezia is happily overgrowing. And then you have this keratinous material, their scales, coated with this dark material. But again, in acne, you tend to see that. And even if you smash that in a slide, not always you find malassezia there. So, but again, in this case, look at the erythema. Very well delimited there. Look for malassezia, okay? Okay, this one was a Devon Rex with that seborrheic dermatitis, again, caused by malassezia. Look at the brownish discoloration there, okay? And, again, look at the scales coated with this dark material. Look at the nails, pigmented. And that's a case of mine, so look at the scales there with this brownish discoloration in self-induced alopecia. Don't move. And again, cats less often has malassezia overgrowing in their skin and causing dermatitis. If you see it in more generalized in cats, be suspicious of an underlying disease and look for an underlying disease. It can be a marker for that, okay? So this is a case of malassezia overgrowth causing dermatitis associated with thymoma-associated exfoliative dermatitis, okay? The cats will have this very exfoliative disease due to thymoma, so it's a paraneoplastic type of disease. They can have this exfoliative dermatitis generalized also, not associated with thymoma, but look for that. Look at the scales, look at very erythematous skin. In these cases, when the skin is not complicated with malassezia overgrowth, it's not this erythematous, okay, but the scales are there. Malassezia may complicate that a little bit too. Then I do twice. And Dr. Marcella just presented a case, okay, of paraneoplastic alopecia associated with cancer in cats. So it's very shiny, and these cats can also have a more generalized malassezia overgrowth causing dermatitis. It's usually, again, I think I mentioned pancreatic cancer, okay, involving the parenchyma and or the ducts. So allergies, malassezia dermatitis can complicate cases of allergies, also add to the inflammation, add to the pruritus, and these animals will be miserable, itchy. So again, think of malassezia overgrowth causing dermatitis in any scaly skin disease, erythematous, greasy, waxy, that has this reddish brown discoloration, lichenified skin, and pruritic skin, okay? And I had some examples here that are very classical. How to diagnose it? Always history, clinical signs. The history are crucial for us to determine that underlying primary disease, okay? These in most of the cases, not to say all of them, it's a secondary problem. Suggestive clinical signs, I think the clinical signs are quite characteristic most of the time. It's more because that brownish discoloration there on the skin. Also the sharp demarcation can help, okay? And presence of yeast. Again, incompatible lesions, we'll talk about numbers in a minute, in response to therapy, okay? So, methods for yeast identification. Cytology, fungal culture, we'll talk about that very often. Skin biopsy, sometimes, okay? I'll tell you a story of a skin biopsy that was done. Okay, let's do cytology. So different ways, and I think Dr. Marcella has mentioned that to you also, that you can collect samples for cytology when you're suspecting of Malassezia dermatitis, okay? Clear acetate tape stripping, it's one that we use very often in most situations. Cotton tip swab, dry superficial skin scraping, and direct impression on the skin. Then let's see when we should choose one over the other. So clear acetate tape, you can use pretty much, okay? I should have done this. So for all types of skin, because again, if the skin is dry or excessive oily, that will help you decide which method to use. For the tape, either one you can do. With the oily, if it's too much, you get clumps of sebum, and then it's difficult for you to, again, evaluate the sample, okay? And you can pretty much use the tape anywhere, folds, interdigitally, any other part of the skin. And one thing I'll just quickly mention is, again, with the Diff Quick, don't use the light blue staining one because it contains alcohol and will damage the tape. I typically only use the dark blue one, okay? Some people do both. I have tried both. I don't think you gain much by doing both. Again, it saves you time, okay? So you rinse it, put a immersion oil on the slide. I like to do a sandwich with the oil. Some people just put it in the slide, sticky part on the slide, and then drop off or two of mineral immersion oil. Okay, what about the cotton tip swab? Definitely for ears, okay, and when the skin is oily and there is kind of abundant material there, because otherwise you gather very little material, okay? And you can try more than one method and decide which one is more effective there. So you can do for folds, interdigital, but sometimes, again, not much comes, and then you roll over a slide and look for some, didn't like that, so. Dry scraping, definitely in oily skin. If you do dry scraping in a dry skin, you won't get anything, okay? So if it's oily, just that superficial is scraping. No need to cause capillary bleeding because, again, you are just sampling the stratum corneum, the outermost layer of the skin, where you're going to find Malassezia, okay? So oily skin, and oh, this is the direct. So it has to be oily skin here because otherwise you don't transfer enough material to the glass slide, okay? And the surface has to be flat, right? Otherwise you cannot use this method. So which is the best method? Again, will depend on the location and the type of lesion. Is this oily? It is dry? And then you make a decision, okay? You can do more than one method there. That's what we expect to see. Okay, and I'm sure Dr. Marcella mentioned that you talked a lot about Malassezia. And so is that you can find bacteria, cocci typically, with Malassezia because the growth factors that stimulate the growth of Malassezia also does for bacteria. So you typically find, not always, but you can definitely find both. Okay, what is the cutoff number? I'm not even going to go there. Look at this. No consensus in the literature. Why? Because there are variation in normal numbers between breeds and within an animal between body size. Then we don't even care about numbers. You don't need to worry about that. So your decision to treat or not will be based on the clinical signs, the history of the animals, and if you probably you'll find one malassezia or so, okay? That's what you take into consideration, not the numbers. Okay? So, fungal culture, again, rarely performed. Usually you do fungal cultures more for research purposes, not on clinics. But for some reason you decided that you want to submit a fungal culture for malassezia for a reason, tell the laboratory, because malassezia, again, to grow will need a special media that contains lipid. And it's called modified Dixon agar, okay? Skin biopsy. So hopefully you're not doing a skin biopsy to diagnose malassezia, but when you have a skin condition that looks very unusual, and you do a cytology there because you're always doing cytology, right? So, and you found some malassezia there, and you look for, malassezia could not be causing this disease, and then you biopsy. That happened. Okay, unusual cases with this case. And it was one of my residents' case. She did see malassezia, but she didn't believe malassezia was causing it. Biopsy said tons of malassezia. All the inflammatory response in the dermis that you expect to see with malassezia. It's not very specific, but treated for malassezia, poof, resolved. Okay? Treatments. Undiagnosed malassezia dermatitis is a common reason for failure in the management of atopic dermatitis. Okay, so it will be there in a lot of our patients. So look for it and address it. General considerations, identify and address any underlying disease or factors. Choose the treatment based on the patient's disease and client's ability to deliver, apply your recommendations, okay? General principles, topical and or systemic therapy. Most of the time, I use just topical therapy. If it's very generalized or I see with just the topicals I'm not getting anywhere, then I add systemic. Again, treat concurrent bacterial infection or overgrowth. Usually, in most of these cases where the malassezia is, you are seeing also an overgrowth of bacteria. It's not a true infection, but you can have an infection also. But that's why after our lecture on the antibiotic use, I don't want, just because you're seeing those cocci there, go ahead with systemic antibiotic at all. Topical would suffice. So when to consider all cases of malassezia dermatitis or otitis. So topical, if it's not the sole therapy, should be adjunctive to systemic therapy, should be always part of the treatment regimen. And again, only if owners cannot administer that at all, which happens, right? So it can be used as sole therapy or adjunctive therapy. Just again, seeing the plethora of products that contain ingredients that can be effective against malassezia. And it's usually, again, miconazole, we have a shampoo. I think more than one pharmaceutical company are producing shampoos with 2% miconazole, 2% chlorhexidine. You are going to see that in the literature there is strong evidence to recommend these shampoos to treat malassezia because of good study designs, so randomized, double-blind, placebo-controlled studies. So that gives strong evidence to that. And I'm going to show you the IAVD recommendations based on the guidelines that they publish. Very good, very detailed, excellent paper for you guys to read, and I have it at the end there. But they make a recommendation of this shampoo, 3% chlorhexidine moderate evidence. But again, I just want to tell you, the other ingredients, it doesn't mean that they're not good. We just don't have studies showing that they are effective. And if you have a shampoo that has an ingredient that's not chlorhexidine or miconazole, but it's a degreaser, for example, and it works well, go with it, okay? And again, there's strong evidence here for this combination of miconazole and 2% chlorhexidine and moderate evidence for the chlorhexidine 3%. And if you are going to use, again, chlorhexidine by itself, at least 3%, can be 4%, but 2% by itself probably won't be very effective. But if you combine with miconazole, yes, it would be a good choice. Okay, yeah, needed for the others. I love Selsun Blue, okay? So it's the human, you have Selsun Blue here, the head and shoulder shampoo for humans. Yeah, I couldn't hear, but it's a good degreaser. It's also keratolytic. I think it has a keratoplastic effect also. And so it's very nice. And they use for Malassezia dermatitis in people too. So definitely, it smells a little strong. And if you have a white dog, don't prescribe it. It will stand the coat yellowish, okay? Eventually it goes away, but. So the degreasing products, benzoyl peroxide, doesn't lather very well, but it's a good degreaser. Tar-based shampoos, which now I think we have one company producing it. I used to have one that I loved, that shampoo, but because of cancer, but they removed it. Selenium sulfide, that's in Selsun Blue, okay? In dish soaps, okay? So because again, Malassezia need that lipid to overgrow. If you remove the lipid, you are indirectly treating it, okay? Sheila, dish soap. Do you have Dawn dish soap here? So it's a very good detergent, and it's mild, and it's very effective. If you have a very greasy dog, like a Cocker Spaniel, sebum everywhere, Malassezia is overgrown, even if it's not related with Malassezia, shampoo the dog, no, bathe the dog using the dish wash, and it effectively will remove the lipid, and then you come with the medicated shampoo. You're not going with 5-10 minutes contact time. Quickly, just to remove that layer of lipid, and then you come with a medicated shampoo that would be more effective that way, and you use less of the medicated shampoo in those cases, so save you money also. What else should we know? The shampoo can be applied to a limited area if the problem is localized, could be the ventral neck, could be the paws. Clip the hair coat may be desirable because if there is a lot of hair in areas, you usually don't have in affected areas because they bite, chew, and break the hair. But if there is, remove that hair. So then the shampoo can have a better contact with the skin and be more effective. A non-medicated bath may be beneficial. That's what we mentioned with the dish soap. Tailor frequency to the patient condition and client ability to. Always you're taking into consideration treatment protocol for any disease. The patient, the disease, extent, severity of disease, and the client, okay? But you know that. So clients, what should they do with these medicated shampoos? Because shampoos don't have a long residual effect. 5-10 minutes contact time so that medication in the shampoo, the active ingredient there, can be effective, okay? Then it also improves hydration. The poor things, they keep waiting there until you rinse them off. So rinse thoroughly to avoid the skin irritation, Okay? Use cooler water when you're bathing any dogs with inflamed skin disease, okay? Because the warm water tends to dilate the vessels, bring more blood to the circulation, and it's uncomfortable. And the cooler water is soothing to the skin, okay? Dry as much the skin after bathing if you're using a blow dryer, again in cool air, okay? Remember, most cases will need maintenance therapy to prevent recurrence because a lot of the underlying diseases are non-curable. The frequency typically varies from once to twice weekly. It varies, okay? Taylor again. We talked about that. To provide residual effect, the companies have thankfully again, manufactured many different formulations that you just leave on the skin. And again, miconazole, chlorhexidine in various concentrations, ketoconazole, acetic acid are typically the ingredients on these residual products that have a residual effect. And usually we use them in between bathing, okay? Can be used as so, as adjunctive therapy, can be used daily to, if you're using those two as part of the treatments, the shampoo, just the topical, let's say wipes or mousse containing chlorhexidine, 3% and other ingredients there, depending on the case, it may need to go daily initially, okay? And then you reduce the frequency until recheck. And again, often used long-term to help prevent recurrences. Be careful with products that contain alcohol because they can not only dry the skin but also irritate the skin. In a lot of these topicals will have some concentration of alcohols. Thankfully, it's not very high, but some dogs, if the skin is inflamed, you apply it there, they don't like that at all. And for focal areas, I really like the ointments. And because there is a lot of inflammation, I like the ones that have some steroid on it. Unfortunately, a lot of these topicals available to us are often ear medications that are applied on the skin. And so they also contain an antibiotic. But remember, bacteria likes to be with the Malassezia organism, so it may not be a concern. And we're using it topically anyway, even if they are not there and we have that extra antibiotic. One thing to keep in mind, and I think I mentioned that at one point, the steroid in a lot of these topical medications is strong, okay, most of the time. Don't let the owner educate the clients about the potential for atrophy of the skin, okay? And it can start even being absorbed. So we have to be very careful with that and explain that to the owner. I don't know if they can buy this kind of products over the counter here, but if they do, you need to really make them afraid of using these products without your recommendation, okay? No refills until you see the animal. Did it move by itself? Focal areas, again, use these ointments, creams with antifungal, plus or minus antibiotic. Example, just pure antifungal, nystatin, miconazole, clotrimazole, terbinafine. Okay, focal areas, those cases, so Malassezia is there. I love this product, mainly Otomax or Mometomax that I use. It works very nicely if it's very focal. So when to stop clock, when to recommend systemic, when there is no contraindication to use systemic antifungals. Topical therapy is impractical or has not been effective. And for generalized and or refractory cases, okay? So which systemic antifungal should I choose? Okay, based on in vitro study, fluconazole typically have the highest MIC. So followed typically with some variation, but fluconazole always highest MIC. Then can be ketoconazole or terbinafine, and itraconazole is usually the one that has the lowest MIC. So based on the studies, I said, okay, but itraconazole would be the first one you would choose, terbinafine second, ketoconazole third, and fluconazole last. But we'll see something about the fluconazole. Recommendations, again, from the WAVD. Again, that's the recommendation, the guidelines that I mentioned to you that were published. So for dogs, they base this recommendation, again, in the very systematic literature review that they did and collected the data, analyzed that data, and sometimes expert opinion, okay, depending on what's available there as far as research proving one way or another. So based on moderate evidence, ketoconazole can be used for the treatment of Malassezia dermatitis at 5 or 10 mg per kg once or twice daily. Or itraconazole, 5 mg per kg once daily or 2 days on, 5 days off. I'm always concerned about this pulse therapy because of resistance, okay? So, but it's less side effects, less expensive, so, and it's shown to be effective. So you decide, okay? Avoid compounded formulations of these products, okay? Not reliable at all. So fluconazole, it's not recommended, but I'll show you something at this time, because current evidence to recommend it, its use is limited to one study where it was combined with cephalexin. And if you see the in vitro studies is the one that has the highest MIC. But what about, that's in vitro, what about in vivo, right? So further evaluation is needed for terbinafine because of partial benefit effects in trial and relatively low concentration in stratum corneum and sebum. And I'll show you a study that showed that at the dosage we typically use, you can go higher than that dosage with the terbinafine, and then you have a better effect. And so this trial just came out not that long ago, really showing that fluconazole actually, they had 3 groups, a group with fluconazole at 5 mg per kg per day, 10 mg per kg per day, 5 mg per kg per day of itraconazole. All the parameters that they used to assess response was not significant difference between the groups, okay? So this study was a randomized, I don't think it was placebo. Positive control there, so let's put it that way, right? But it was a nicely designed, and again, it's showing that fluconazole, I don't know the cost, is probably cheaper here than itraconazole, I presume. So it's something you can definitely try based on this study. As far as terbinafine, it's just because there was this pharmacokinetic study that showed that terbinafine at 30 mg per kg per day, that's a commonly used dosage, the concentration barely gets above the MIC, and that's an MIC that they got from the literature, okay, in the stratum corneum and sebum. And then they recommend, so if you're using terbinafine to treat fungal infection, so Malassezia, for example, use a higher dosage. Which dosage do you typically use? Because I know you use Dr. Marcella. 40? No. 30 to 50? 50, so she goes very... Yeah, okay, within that range. I used to do 30, so until this study. So WAVD, what they recommend for cats, based on a sole investigation of itraconazole and its safety profile, it's currently recommended as the first choice for Malassezia dermatitis at 5 to 10 mg per kg once daily of 5 milligrams per kilogram once daily for 7 days, then 7 days off, like the protocol you use for dermatophytosis tubes, because of, again, it concentrates in the stratum corneum for a long period of time. So you can do this pulse therapy there. Avoid compounded. So treatment duration, I promise. Treat until clinical resolution, yes. Repeat cytology if needed. If I don't see any rather no lesion there, I'm not doing cytology again. I will get stratum corneum, I may get 1 or 2 malassezia, but they live normally on the skin. I'm not necessarily do that. Recheck, it depends every treat. The important thing is that when you're treating, you recheck your patient. Clients don't know, cannot assess if it resolved or not. Topical therapy with shampoo and reducing formulations are often used long-term. So refractory or recurrent cases consider failure to identify or control the underlying disease, lack of client compliance, obviously, right? So if they don't do what you recommend, it won't help. Inappropriate treatment protocol. True resistance. To biofilm formation, for example, or other factors. And that has been shown that Malassezia can develop resistance to antifungals it's demonstrated in vitro, okay? So, and one thing that they did, they use fluconazole consecutively multiple times in vitro against Malassezia strains, and their MICs increased. And what they noticed also, cross-reactivity against other azoles. Initially, they are not resistant. Later on, they become resistant, or the MIC increase. So we don't have a break point to say if it was really resistant or not for Malassezia. And that's what we are saying here. And when you isolate Malassezia organisms from dogs with atopic dermatitis that have been exposed to medications, their MICs, the MICs of those strains will be higher than compared to normal dogs, okay? Prevention, there will be the last thing. Prevention, identify and treat an underlying disease. Use long-term topical therapy. Summary, Malassezia dermatitis typically associated with an underlying disease. We mentioned that multiple times. Be suspicious of Malassezia dermatitis in erythematous, very nicely demarcated or not, scaly, oily, lichenified skin with red-brown discoloration. Look for Malassezia organised in lichenified skin. I mentioned that before. Diagnosis should be based on history, compatible clinical signs, presence of one or more yeast on cytology in response to therapy, okay? And bacterial overgrowth may also be present in cytology. Choose the treatment based on disease severity, sites affected, and ability of the owner to follow your recommendations. Maintenance therapy will be required in case where an underlying disease cannot be cured. That's the guidelines published. So very thorough, detailed document. They have a summary document also because of pages, and so you should take a look at that. Okay, do I have 0? So time for questions? I don't know. Am I doing the next one now? Without? Yeah? Okay. So, but any questions about Malassezia dermatitis / No? Okay. So now is the food.